Welcome back to the JoyAge International Symposium 2022 Day 3. Before we start, we would like to thank our speakers for their generosity of allowing us to record today's session and make the resources available online later. To our audience, you're more than welcome to share the recording to your colleagues and fellow researchers later when the resource is available. Just tune in to our website. Should you have any questions for our speakers, please do not hesitate to type and send us through the chat box anytime during the presentation. We will collect these questions and address them later in the Q&A session. Today, we will delve into the prevention, assessment, and treatment of elderly mental health issues. We are very honored to have Professor David Conn from the University of Toronto and Professor John Hirdes from the University of Waterloo with us today. Professor David Conn is a professor in the Department of Psychiatry, University of Toronto, and is a geriatric psychiatrist at Bathurst. He is also the founding co-chair of the Canadian Coalition for Senior Mental Health, which developed the Canadian guidelines for substance use disorders among older adults. Today, Professor Conn will present to us the Canadian guidelines for preventing, diagnosing and treating depression in older adults. Professor Conn, please.
Thank you, Bridget. Thank you so much. It's a pleasure to be with you this morning, your time. And I want to thank the organizers, particularly Professor Lum, for inviting me. And I'm very excited to learn about the JoyAge project, which sounds quite amazing. I'm going to share my slides now. Hopefully that's going to work. So I'm going to be talking to you a little bit actually about our National Coalition for Seniors Mental Health. And I think you'll find that quite interesting. We're celebrating our 20th year this year. And then I will focus quite a bit on our new updated guidelines for depression among older adults. And I'd like to finish with talking about a few promising models of care. A little bit different, I think you'd be interested in. One's called the Fountain of Health, and the other is called Project Echo. I work at Baycrest. It's a large geriatric center affiliated with the University of Toronto, and we have a big research institute in neuroscience, a hospital, very large nursing home, independent assisted living for older adults, as well as a variety of other very interesting programs, including an innovation center called the Center for Aging and Brain Health Innovation, or CABI. This is a picture actually of our nursing home, the atrium of our nursing home, which was built almost 20 years ago. And I thought it would be interesting. We have quite a few connections to Asia, one of which is actually having medical and nursing students from Beijing, from Peking Union Medical College, spend the summer with us. And we've been doing this now since 2012, but of course the pandemic closed things down for a few years. We hope to renew this again in the near future. So the Canadian Coalition for Seniors Mental Health, as I said, we're celebrating 20 years. Our website is at the top left there, so you can get a lot of our materials and guidelines from that website, and we'd love to have you connect, take some of our resources, and even join us. It's free to join our coalition. So what is a coalition? It's a group coming together where the goal cannot be reached by any one individual or group, and the participants should include a diversity of individuals and groups who represent a concern or a geographic area or population. So the Canadian Academy of Geriatric Psychiatry initiated the project in 2002 when we had a national symposium, brought together a lot of different stakeholders. And after a long meeting, everyone decided that we needed to work together to form a national coalition focused on the mental health of older adults. So this was the original steering group that came together. So on the far right there is myself 20 years ago. And it was a very upbeat meeting. Everyone was full of energy. And as you can see, people were quite excited, and there was even music. So our mission is to promote the mental health of older adults by connecting people, ideas, and resources. And this was our initial steering committee. And as you can see, the organizations that came together represent many different health disciplines. The government were there to support it. Alzheimer's Society, Mental Health Association, nurses, psychologists, physicians, an association for older adults, social workers, of course, caregivers, and so on. So the strength of our coalition was really the representation from so many different disciplines, all working together. And we were lucky in that our government, federal government, gave us funding to develop national guidelines. And these were our first set of guidelines that came out in 2006, including guidelines for depression in older adults, as well as the assessment and prevention of suicide, critical issue, of course, with older adults. And, you know, we developed guidelines, and then we developed lots of materials, tools, more convenient instruments for clinicians to use, as well as materials for the public and for older adults. And on the right there, for example, is one of our pamphlets translated into many different languages, which is so critical. And we had a partnership with a huge drugstore that goes across Canada, and they distributed a lot of these materials for us. We had a formal evaluation of the guidelines by an outside agency. And one of the things they pointed out was that by creating guidelines, it's not just guidelines, and it's not just helping clinicians to do the right thing, but creating guidelines leads to all sorts of other activities, including education and training, research, advocacy, and so on, and even affecting policy in some areas. So over the years, we were able to grow and gradually get more funding, pretty small scale funding compared to the Jockey Club, but nevertheless, it was important for us to have enough funding to be able to continue, because people don't pay to join the coalition. So we need projects to support having an executive director, for example, which is very, very critical. So most of the work doing all of these activities is volunteer work. So we persuade our colleagues from all disciplines to work with us pretty much for free. But, you know, I think when people come together to do good work, they're motivated. So then about 5 years ago, we started to get more significant funding, which was great, and a number of really important projects that were developed in the last few years. The first one at the top, transforming healthcare for dementia prevention, health behavior change as first-line medicine. I'll come back to that later on when I talk about the fountain of health, which was linked to this project and one of the partners. Recently, we've got some new funding. The first is actually quite interesting, maybe of interest to you, in that we're developing guidelines for healthcare providers and social service providers around how do you address seniors' isolation and loneliness. Huge issue. And of course, the pandemic has made this problem even greater for older adults. And so we're just starting this project. We actually had our first meeting today of our working group from across Canada. And it's an exciting project. There's a lot of work been done in this field, but what should a social worker or a physician do when you're trying to help a patient? We also got recent grants from the Public Health Agency of Canada to develop more guidelines. One is on the behavioral symptoms of dementia and another on anxiety and anxiety disorders. So this is a very interesting paper that was published in The Lancet last year. And I don't know how they did this, but basically they got information from all over the world. And what it shows is the increase in depressive and anxiety disorders right across the world in 2020 due to the COVID-19 pandemic. And, you know, in every country, there's an increase. You have to wonder about the accuracy of the data, of course, because no doubt each country was using a different method. But, you know, in many countries, we're seeing about a 25% increase in these disorders. And I think it affects all ages. It certainly affects older adults, although there's some evidence that it actually is affecting younger people even more than older adults, and that older adults have a certain degree of resilience that is coming through during this time. So the Canadian guidelines on the prevention, assessment, and treatment of depression, and you can download this document from our website. And this is an updated guideline. So we took the previous guideline and we tried to figure out what had changed in 15 years, what was new, what new research was out there that was relevant. And so there's two sections to these guidelines. The first describe the new or modified recommendations, and then there's a side-by-side comparison of the two, so you can read the whole of the guideline together. And these are the topics that are included in the document. So really everything from prevention through assessment and screening, and then a whole variety of different types of interventions. And then, you know, the interventions vary according to subtypes of depression, focus finally on special populations and models of care. This was the guideline update group, the more recent one, great group. And then this was the original group that worked in 2006. So, you know, when you're developing guidelines, of course, you have to do all the literature searches and look at all the databases and figure out which articles are relevant. And it's a lot of work, of course. So we did that. We had a very good research assistant that helped us. And ultimately, we use the same system with both sets of guidelines in terms of categorizing the levels of evidence. It's a relatively simple approach. It basically says that if you have very good evidence, so meta-analyses or lots of randomized controlled trials, then that's, you know, high level of evidence. And that would generally lead to a stronger strength of the recommendation. Whereas if the evidence is not really based on good research, maybe more on the opinion of experts, then the strength of the recommendation drops to D. But I must say with guidelines, sometimes the D level recommendations are just as important as the A level. And of course, there are many types. Clinically, there are many types of depression. It's not just one disorder. So we tend to focus, of course, on major depressive disorder or bipolar disorder or persistent depressive disorder, the very long-term depression. But there are lesser depressions and adjustment disorders and normal bereavement, even depression that occurs in some personality disorders, or mood disorders, of course, due to specific medical conditions or substances, which is so common in older adults. And these are the classic symptoms of a major depressive episode that we take from the DSM. And basically you need 5 out of 9 symptoms for at least 2 weeks with distress or impairment in functioning. And certainly we, and I'm sure you feel that a biopsychosocial model is optimal. So in trying to understand a person and why they're having difficulties, you know, it's no good if you just say, well, depression is a chemical imbalance. There may be some truth to that in some cases, and we know that neurotransmitters are affected, but there are so many other factors that come together. And I think many of you are from the School of Social Work at the university, so you'll appreciate this for sure, that the social and environmental factors, the psychological factors, these are critical in trying to understand a person, as well as looking at their history, the predisposing factors and precipitating factors, but also the factors that perpetuate a problem, as well as the protective factors, the strengths that a person may bring. And we're always trying to figure out, yes, what is the reason for the depression? And in most cases, there are reasons, although there are some people who have mostly a chemical disorder who don't seem to have a clear precipitant, but that's relatively rare. So let me go through some of the recommendations. So the first guidelines had no recommendations on prevention, and that's a big change. Obviously, in the last 15 years, health promotion and prevention have become much more prominent and much more critical. As Ben Franklin said, an ounce of prevention is worth a pound of cure. This is an interesting, very interesting image from the Boston Foundation and the New England Healthcare Institute. On the left, it says, what are the things that make us healthy? And they say it's 50% healthy behaviors, plus the environment, plus genetics. And then at the top, access to care. Care is about 10%. But what do we spend our money on? This is in North America. Well, mostly we spend our money on medical services and very little on helping people to lead healthier lives. So something's wrong here. And although research, this is Chip Reynolds from Pittsburgh, one of the leaders in depression, the depression in older adults field in North America. He wrote that although research on prevention is in its infancy, prevention may be an alternative strategy to further reduce the disease burden of depression, which has been described as a global public health priority. There are different ways of categorizing prevention. One system says that universal prevention focuses on the general public, selective at individuals or groups that are at higher risk of developing the problem, and then indicated prevention, which focuses on individuals who are identified as having early symptoms or biological markers. And I think this is where a lot of the work is going on in right now in terms of indicated prevention. You know, a lot's been written about risk factors for dementia and potentially how to prevent dementia. This is from the Lancet Commission, suggesting that we could reduce the prevalence of dementia by about 1/3 if we were to tackle all of these problems. What about depression? We seem to know less about how we might prevent depression. Some of the recommendations. So one is that a variety of interventions focused on reducing social isolation and or loneliness in older adults have also demonstrated a reduction in depressive symptoms in addition to reducing loneliness. The studies were primarily group-based and in long-term care, and they include things like reminiscence therapy, physical exercise programs, video conferences with family, horticultural therapy, and gender-based social groups. You may have heard of social prescribing. This is a means of enabling primary care services to refer patients with social, emotional, or practical needs to a range of local, non-clinical services, often provided by the voluntary and community sector. So there's quite a bit of work suggesting that social prescribing may reduce depressive symptoms. This would be among older adults who have mild or moderate symptoms of depression or social isolation or loneliness. It's quite an overlap here, as you can see, between depression and isolation. A stepped care approach, and I believe that's an approach you're using for JoyAge, which is great. This is from the Netherlands. So a stepped care approach, for example, watchful waiting, cognitive behavior therapy-based bibliotherapy, in other words, giving people a book on CBT, then problem-solving therapy, or the next step would be referral to a primary care program for antidepressants. But there is evidence that if you take this approach with people who have symptoms but not the disorder, that you can significantly reduce the incidence of depressive or anxiety disorders by as much as 50%. So this is a critically important study. as I say, carried out in the Netherlands. Physical activity, it's great for everything, but there's no doubt that there's quite a bit of evidence that high levels of physical activity are consistently associated with lower odds of developing future depression. And this is across all ages, including older adults. So we certainly should encourage our patients with low levels of physical activity to become more active. This is simple, but clinicians should utilize the instilling of hope and positive thinking as important therapeutic tools in the prevention of depression. I think, busy clinicians, physicians, other nurses who are overburdened, working hard, feeling very stressed. I mean, the pandemic has been terribly difficult for health professionals. Sometimes they're burnt out and they lose the capacity and energy to instill hope. But this is a critical tool, often neglected. There are recommendations on screening and assessment, and in the box on the left, these are all individuals who are at higher risk for developing depression, such as those who are recently bereaved. But a whole list here, and so screening would be ideal if one could reach these individuals to make sure they're not developing a serious depression. And when it comes to screening tools, we make some recommendations. These are widely used tools like the Geriatric Depression Scale or the Patient Health Questionnaire 9, or the Cornell scale when you have depression in dementia. We talk about an optimal assessment, and this is, ABCs, the basics, but of course, it's always critical to do a full assessment that might include some physical exam and blood work to rule out any medical conditions that are actually mimicking depression, like hypothyroidism. An assessment should always focus on safety, of course, and driving is a big issue with older adults, and we have to be careful around safety. What about psychotherapies and psychosocial interventions? So yes, so promising evidence for exercise and mind-body interventions such as Tai Chi, yoga, mindfulness-based stress reduction in reducing depressive symptoms, and again emphasizing physical activity. Pointing out, though, that clinicians should use their judgment in recommending the type of exercise and duration, taking into account comorbidities, physical capacity, and level of motivation. So, a lot of older adults may not be able to go and exercise rigorously, but they can do stretching or chair exercises. They can also be very helpful. And we note that psychotherapies, talk therapies, have been well studied with older adults. Cognitive behavior therapies, problem-solving therapies have been shown to benefit older adults with depression and medical comorbidity as well. Can be individual treatment or group treatment. At my hospital in Toronto, we have a day program for people with depression, and it's mostly group-based therapies that work really well. And there are a whole variety of other therapies that lower down in this page that are listed, all of which have been shown to be of some benefit. We also note that internet-delivered therapies may be comparable to face-to-face treatment and may improve access to services for individuals in underserviced areas or those with mobility issues. And of course, through the pandemic all over the world, virtual care has become much more prevalent. A little humor here. So go home and let your dog lick your face. Dog saliva is the most effective antidepressant you can get without a prescription. Is this true? Well, probably not, but pet therapy is certainly effective, and so many older adults can benefit from having a pet. So yes, medications, and of course our guidelines do talk a lot about medications, optimal medications, and I won't go into a lot of detail here. If you're interested, you can read the guidelines, but we do actually recommend two particular antidepressants that we believe would be the safest and those with lowest side effects. And those are sertraline, which is an SSRI, and duloxetine, which is an SNRI, working on both serotonin and norepinephrine. But we give advice on, using the safest type of antidepressant with the least likelihood of developing side effects or drug-drug interactions. And we suggest that if you start someone on an antidepressant, that they should be seen soon, every 1 to 2 weeks, in person or virtually, to assess response, side effects, and to titrate the dose. And this is really, really important. One interesting side effect from antidepressants that some people don't know about is, by and large, antidepressants are really safe and well tolerated, but there is a side effect which can be quite serious, and that is a lowering of the sodium level, which is called hyponatremia, and that can actually make you very sick. And so it's something we suggest monitoring for, usually within the first 2 to 4 weeks. And certainly in someone who's at risk, higher risk of developing low sodium. And there are certain antidepressants where this is less of a risk, so we make a note of that. How long should people stay on antidepressants? Well, if they've worked, then we say a minimum of a year, and this is well known, and this idea has been around for many years. We also say that if people have had terrible, severe depression that's been really hard to treat or actually required ECT, then the best evidence would be to take antidepressant maintenance treatment indefinitely, unless there's some real concern about side effects. The guidelines, and I won't go into detail, do give specific advice around more severe depressions, and the kind of interventions that may be required. Treatment resistance is a challenge. So only 50% of older patients respond to first-line treatment, and less than 40% reach a full remission. So if we're not getting a good response, we have to check, is the patient actually taking the medication regularly? Are they using alcohol or other substances? Are there medication interactions? Are we sure about the diagnosis? Are there any medical conditions that we need to be concerned about, including low sodium? And then there's advice about what to do, which includes augmenting with another antidepressant or using the mood stabilizer lithium, or in some cases, actually using an antipsychotic medication, or perhaps some people might benefit from a different type of psychotherapy. And all of these are good interventions that have to be considered. We do mention that lithium can be a bit of a tricky drug to use in older adults, and that we have to be very careful that the person doesn't become toxic, and they need regular blood tests. And yes, there's advice on people with very severe depression and the kind of interventions that may be required, but I'll skip that. One very interesting and new recommendation relates to something called RTMS, which is repetitive transcranial magnetic stimulation, which is a very up-and-coming treatment. It's very benign. You have to go 5 days a week, usually for at least a month. So it's time intensive, but unlike ECT, you don't need an anesthetic. There's not a lot of side effects. And there's some growing evidence now, including with older adults, that this may be a pretty good treatment for some people. So, so for the first time, we included this as a potential treatment for older adults. There's a lot of interest now in how older adults actually metabolize drugs, because based on your genes, your genetic profile, some people may be very sensitive to side effects or may need higher doses. And the only way to find that out would be actually to do pharmacogenetic testing. It's available, but in my country, you have to pay for it, and it's quite expensive. So we're not recommending it yet, but I think in the future, we'll see it used much more. And the guidelines go on to make recommendations regarding some special populations. Depression with dementia, of course, is really, really common. It can be harder to diagnose, and there's a lot of overlapping symptoms. There are actually different criteria that have been proposed for depression with Alzheimer's disease. Our recommendation is actually that people with mild depressive symptoms or short-lived depression should be treated with psychosocial support and supportive interventions first. And we're not that keen on antidepressants in this population. We do use them. Certainly, if someone's got a persistent depression, we would try an antidepressant. But the studies have not been that impressive in this population. And then the final set of recommendations focus on models of care. And originally, we talked about how it was very important to address physical, functional, as well as psychosocial needs of older depressed adults, and that interdisciplinary involvement in care, whether in primary care or specialized settings, was most definitely optimal, and that it's very important to implement a model of care that promotes continuity of care, because older adults generally respond better to a consistent primary care provider. And then the new and updated recommendations include some of these studies that were done, particularly in the United States, regarding collaborative care, particularly in primary care. And some of those studies focused on bringing in depression care managers into their practices who would actually use a stepped care approach and then only referral to the physician if the depression was getting really bad. But these studies showed improved outcomes for depression and reduced suicide ideation. So we certainly suggested that these kinds of interventions were very valuable. We also emphasized that access to clinical, senior-friendly virtual care options should be available, and that older adults should have appropriate equipment and support to ensure effective and efficient communication. I want to mention another set of guidelines you might be interested in. These are called Guidelines for Comprehensive Mental Health Services for Older Adults, produced by our coalition in conjunction with the Mental Health Commission of Canada. This is an image from those guidelines with the older adult at the center, family and friends around, some of the determinants of health around that, and then all the array of different services that might be needed in the community, in long-term care, in hospitals, in different settings, supports, and so on. Lots of information in those guidelines about optimal models of care and resources. And this group also produced a compendium of good practices for improving seniors' mental health in Canada. This is available on the website of the Mental Health Commission of Canada. And some of the things they mention in there are promotion and health promotion and prevention. So the Fountain of Health program, I'll tell you about in a minute. Mental health first aid seniors is mentioned, and I believe you're using that in the JoyAge program. Peer support services, community outreach, of course, and then collaborative shared care models where mental health professionals actually embed themselves, perhaps part-time, in a primary care practice or location, perhaps working with a primary care team. And this is a model that's been utilized for mental health services in Canada quite successfully. The Fountain of Health, and the website for the Fountain of Health is up there. This is a very interesting program. It was started in Nova Scotia, Canada, by one of my colleagues, Carrie Lee Cassidy, who's a psychiatrist in Nova Scotia. And, you know, why is there so much difficulty around prevention? This is a great quote from the American College of Preventative Medicine. It says, while evidence clearly shows that lifestyle interventions and behavior change to be the most effective first line of therapy for reducing chronic disease, the majority of physicians are not following these guidelines, saying that they don't have the right knowledge, skill, or confidence in counseling patients about lifestyle interventions. So the Fountain of Health teaches clinicians in their practices to use tools to work with their patients to improve some of their lifestyle behaviors. It uses some simple CBT approaches. And it focuses on these 5 areas: so social activity, positive thinking, physical activity, mental health, and lifelong learning. And the idea really is that a clinician works with their patient and says, you know, I've noticed that you're really very socially isolated, or I noticed that you're not very physically active. Would you consider setting a small goal to make some changes? And so the Fountain of Health has many tools on the website that a clinician can use with their patients. And basically, it's collaborative. The patient actually sets the goal. The clinician supports using a SMART goal method, and then following up regularly. And SMART goals have to be specific, measurable, action-oriented, realistic, and time-limited. And, you know, you can explain this to the person. It's no good to just say, oh yeah, I'm going to be more physically active. You have to say, what are you going to do? How many times are you going to walk this week and each week? For how long? What time? How are we going to measure that? And so on. And I've been involved a bit in this project with Dr. Cassidy, and these are a few publications that have shown really good behavior change. In the bottom study, and this was over 900 patients who signed up for this, 88% either partially or fully reached their goal. And they're often small goals, but this was very encouraging. And a second project I wanted you to know about is called Project ECHO. That stands for the Extension of Community Healthcare Outcomes. This is an exciting educational program that's designed to improve the capacity of staff in primary care. And it was started by a very charismatic liver doctor called Sanjeev Arora at the University of New Mexico. And it's a hub and spoke knowledge sharing network, weekly sessions focused on a particular area of healthcare. And it sounds very simple. You basically sign up and you attend a weekly session. And Dr. Arora, he was a liver doctor, he still is, but he was really concerned about patients in the distant rural areas of New Mexico who weren't getting treatment in time. So he started this program to teach primary care physicians and other clinicians how to treat hepatitis C, and published it in the New England Journal of Medicine when he found that the outcomes were just as good as when the patients were actually seen at the big medical center in Albuquerque, New Mexico. He's also very, as I say, he's very energized and charismatic. He's been able to get a lot of funding. The model has now spread to more than 50 countries around the world. I don't know if there's any echoes in Hong Kong. In Canada, our government in Ontario has invested in these programs. And my center at Baycrest, we've been running echoes for the last 4 years now. So unlike traditional telemedicine, where you're just treating one patient, you're training a lot of primary care staff and multiplying their knowledge. It's a very exciting program, works really well. Each session is basically a short didactic presentation by an expert, and then cases are presented by the learning partners. And there's a a great discussion where everyone's learning from everybody else. It's very interactive. It uses Zoom. It's been using Zoom for years, but and then the person who presents the case gets recommendations from the group. As it said here, though, ECHO is all teach, all learn. Everyone's learning from each other. The experts are learning from the participants and vice versa. And there are now ECHO hubs all over the world. It's really quite amazing. And great energy that comes from this program. It's a great culture. So yes, and we use the ECHO model during the pandemic to reach long-term care nursing home staff and to support them and give them the right information they needed during the pandemic. We also got funding recently for an ECHO that goes beyond our province of Ontario, right across Canada in mental health for older adults. The last thing I wanted to mention is that although virtual care has become much more prevalent now during the pandemic, we've been involved doing virtual care for many, many years, trying to reach the distant rural areas of Ontario. Ontario is huge. So the distance from Toronto at the bottom to some of these communities in the Northwest is about 2,000 kilometers. And we have a great, for many years, we had this great network which allowed us to do video conferencing. Now, of course, everyone can do video conferencing on their PC. But for many years, this was not possible. So, sorry, I just lost the last few slides there. Come on, it's finished. Yes. So yes, in conclusion then, our coalition is celebrating 20 years of national leadership in seniors' mental health. Our depression guidelines have been updated, and they now include prevention strategies and greater emphasis on a variety of psychosocial interventions, including physical activity, and updates on evidence-based models of care, including virtual care. And then I've mentioned some other useful programs that I think you might be interested in, including the Fountain of Health and ECHO. And I've left my email address here. If you have any questions or want to get in touch, please feel free. I want to thank our Executive Director, Claire Checkland. And I'm serious, if you want to join the CCSMH, that's our website. You can join as an affiliate for free. And then you get our materials. So we'd love to have some international affiliates. So, and I'm going to stop sharing there. I'm very happy to take your questions or any other comments.
Right. Thank you, Professor Conn, very much indeed for a very fruitful sharing of multiple projects. Maybe I'll take the advantage and kickstart with a question that really, I have this curiosity in me, because when you mentioned how ECHO actually can serve the community better, especially in a time of COVID when people don't have those face-to-face interactions. One thing we observe in Hong Kong is that we also try to assist the older adults with digital mental health services. But then at the service end, probably because they typically have lower digital literacy than the general public, there are additional supports we need to assist them. Do you have any experiences or any sharings on how to really boost the communities from the receiving end, probably, and how do we support them better to be beneficial, to benefit actually from the digital mental health services?
Yeah, thank you, Bridget. That's a really challenging question. So when it works well. And, lots of older adults, it depends what age you start at. Let's say 65, okay? And 65 up to 100, right? That's a huge range. And then we think of, many older adults who are very literate digitally and using computers and have no difficulty. But then older adults, particularly the very old, who haven't really ever become familiar with computers or smartphones, or who are starting to have cognitive impairment, start to lose the ability to use things like Zoom. And it can be a real challenge. I don't think we paid enough attention to this. We're so excited that some older people are able to benefit and we're able to connect with them. I will say one thing we've used is a thing called the telephone. So actually a lot of our physicians and other health professionals have been providing care through the phone as opposed to video. And almost everyone can use the phone. And our funding agency and the government of Ontario has expanded, the billing for phone call services, because previously it was very restricted. They didn't want to allow everyone to just offer care. And then everyone got very concerned that too many doctors were just using the phone. They weren't, during the pandemic, they didn't see their patients at all, and this was not good, obviously. So it's trying to find that right balance. But I do think that we take the phone for granted, but can actually be a very effective tool for those who not very digitally literate. But I think we could be better at teaching older adults, particularly those who are sort of with mild cognitive issues, but still very capable, how to actually learn. And I think there's a lot of work on simplified tools as well, simplified instruments where you can very, very easily connect with a push of a button or two. And I think that we could do better in this regard as well.
Oh, thank you. Thank you. That's really useful tip to not take phone for granted and think about other, how do we use this technology better? Professor Terry Lum has a question asking if you could share a little bit more about the differences and probable similarities and more things between the fountain of house versus echo model.
Certainly, yes. So, and I know I went through it quickly, so it's hard to grasp everything. But the fountain of health, and they're both really aimed at primary healthcare providers or family physicians, primary care. But so the fountain of health really teaches primary care providers and specialists too. It doesn't actually have to be primary care, but it teaches us as clinicians how to be better at motivating our patients, our clients, to make the kind of changes in their life that could be meaningful, and setting individual goals that they can attain, and being very supportive and encouraging. It uses as well, I think, some very simple techniques. For example, a lot of people might say, well, my parents died young, so I'm not going to bother doing anything because I know that I'm going to die young, right? So there's no point, right? So that's simply not true. If you look at genetics and genetic factors, there's quite a lot of evidence that genetics only account for about 25% of longevity, not what we think is, might be the other way around. And so you can actually give people information that would help them, motivate them. You can explain how exercise changes brain plasticity and is good for not just your heart, but so good for your brain as well. Give them very simple little snippets that would motivate them, and then give them ideas about how to set very simple goals. And we all know how hard it is to do the right thing. For example, to exercise as much as we should. Although when I visited China and I saw in the park so many older adults doing Tai Chi, I was amazingly impressed, at how beautiful that is. So there's great motivation there. But yeah, getting people to make small goals and then to follow up with them, that's the fountain of health. And the results are really good and quite remarkable. And then ECHO is much more of an educational program. It's designed to improve the capacity of frontline primary care staff to deliver optimal care. Let's say they want to learn more about how to, so a lot of our ECHOs, for example, are not just focused on mental health of older adults. We have ECHO programs that look at just caring for older adults, and they will have sessions on dementia, depression, but also on a whole range of other issues pertinent to older adults, so incontinence, falls, and so on. So by the time someone's done a whole course, they've actually learned a lot of new techniques and gained a lot of new information about caring for older adults. And the learning method that ECHO uses, there's a kind of a secret sauce, we call it. There's something very special about the way people interact on echoes, and it's not just the expert, you know, saying I know everything and I'm going to teach you. It's like everyone's learning from everyone else, and so it's very powerful and engaging. We really love this program.
So, David, when you say primary care staff, do you refer more to physician, or does the, for example, the ECHO extend to staff in nursing home or in community-based healthcare?
Yeah, absolutely. So we run our echoes. We have community echoes where the staff are in the community. The majority of the people who attend echoes are actually nurses, social workers, occupational therapists, and physicians and nurse practitioners. Usually we have about 20% physicians and the rest are from other health disciplines.
Okay.
And we run echoes that focus on long-term care as well in nursing homes.
Okay. Do you have a version of ECHO that is more tailor-made, for example, for the health worker, rather than, you know, they are not professionally trained, right? They are not physicians, but they are just, you know, day in, day out helping the older person. So we are thinking about how to expand their capacity to be more sensitive to the mental health needs.
Right, because I know the JoyAge program, I gather, is you have ambassadors, you're training all sorts of people, right? Many people, I think, using
we use the mental health first aid.
First aid, So I mean, the ECHO model could work very well as well for training of ambassadors. I think it could be fantastic, engaging approach. I think. Okay. Maybe we should have a combined Canadian Hong Kong strategy or project.
We would love to engage more. Another one is Toronto is also a very diverse community with people from all cultures. So do you need to adjust your protocol or for depression, older person, to different cultural group, or pretty much once so what's your experience the last few years?
Yeah, and I think that's one thing our guidelines could have more information on different cultural groups, different ethnic groups, because with mental health, we know that each different ethnic group culture approaches mental health differently, right? And there are some cultures where there isn't even a word for depression in the language, and I know, actually, of interest perhaps to you, we have a very large Chinese population in Toronto, so more than 10% of the total population. And some of our hospitals, like Mount Sinai Hospital, they've developed some very specific program for the older Chinese population in Toronto. And they used a very different approach. They established a kind of wellness center. And that was the way they would draw people in. They didn't say mental health on the door, it said wellness. And they found this was an effective way of engaging people and providing supports and ultimately providing information that might be useful.
Yes. No, in Hong Kong, the approach we have been using is, we have an elderly center, which is more traditionally more as a healthy aging center. But then over the years, we kind of like Christmas tree, we put a lot of, ornament on it. So they now have a services to support caregiver for people with dementia. They also have transitional program for people with mild to moderate dementia, but stable. Then they will transition from medical setting back to community setting. So we have a transition program for people with dementia. And then right now, the JoyAge project, we kind of add another ornament, the depression specific services over there. So actually we struggle this project, whether this is something we should continue adding ornament into a healthy aging program. or we should develop more community-based health, quote-unquote, health center for older people. So if I pose this question for you, so what since you are also the director of the biggest elderly center, not center, but the cluster, services provider in Toronto. So what will be your suggestion?
I like your idea of ornaments, of different levels and a stepped care approach, obviously. I believe you use a stepped care approach, right?
Yes,
In JoyAge?
Yes.
That makes so much sense to me. And starting with preventative techniques, like Fountain of Health, I think is a good one. And just layering on different strategies and approaches, including using the power of education as well. Like in the ECHO program, I think.
Exactly.
Very valuable.
I think the ECHO should integrate or and the JoyAge should have some kind of marriage to extend our education program.
Yeah.
I am aware of the time, so let me pass the microphone back to Bridget.
Thank you, Terry, for the very stimulating conversation between Professor David Conn. And it totally sold me about CCSMH guideline. I actually just downloaded from the website and encourage everybody to subscribe to the website. And then you can find very valuable resources there as well for our JoyAge website. So again, thank you, Professor Conn. Your sharing gives us a very comprehensive understanding of approaches and techniques for dealing with geriatric depression. And additionally, gives us a wonderful chance to hear the international viewpoints at our symposium. So again, thank you. And we'll move on to the second session of our symposium. Right. So
thank you, David.
Thank you. All right. Good morning, everybody. So now let's move on to Professor Hirdes' talk. So Professor John Hirdes is a professor in the School of Public Health Science, University of Waterloo, and is the Senior Canadian Fellow and a board member of interRAI. He is also the chair of interRAI Network of Mental Health and the interRAI Network of Canada. And today he will be introducing the interRAI assessment system and how it can identify mental health problems. So good evening, Professor John Hirdes. I know it's really late evening there in Canada. Appreciate your time joining us from the other side of the world.
I'm delighted to be here. Thank you for having me.
But also I want to add, John is in a conference now, so he is delivering his talk from a hotel, so which I really appreciate. From your busy time, you take your time out from the conference activity and join us here. Thank you so much, John.
It's great to be here. Thank you.
Okay, so I will let you start. I will stop the video and then.
Okay, sounds good. I'll start with my slides here and. Okay, are you able to see the slides all right?
Yes. Perfect.
Okay, great. Thank you. Well, thank you, everybody, for having me. It is a little bit late here. I'm in Quebec City, actually at an interRAI meeting, or one of our first face-to-face meetings after more than 2 years of being apart due to the pandemic. So it's wonderful to be able to reconnect with our colleagues again and to be able to connect with you at such a great distance via this webinar. So what I'll be talking about is how we can use interRAI assessments to identify and to respond to the mental health needs of older adults across the continuum of care, so that we can connect them into those excellent programs that my colleague David Conn presented earlier with some of that groundbreaking work being done by the CCSMH. So these two talks, I think, will complement each other nicely. What I'll do is I'll give you an overview of interRAI's research on mental health instruments, and then I'll do a deep dive into 3 specific examples. One, how we can use these instruments for outcome measurement to see how people are doing over time. The second, how we can use it for care planning in a variety of different sectors. And then I'll show you some work that we've done to evaluate the impact of COVID-19 on mental health in a long-term care setting. So it might be first helpful to introduce you to interRAI if you're not familiar with it. interRAI has over 140 different researchers and health and social service professionals and policy experts from more than 35 countries around the world. We're a not-for-profit network. Our focus is on developing comprehensive assessment instruments that can help us identify the strengths and preferences and needs of vulnerable populations of all ages. So the way we do this is through multinational collaborative research to create these assessment instruments, but more importantly, we also work together to examine how we can implement them effectively and how we can use them for a variety of different applications that I'll talk about today. As I said, we have about 35 countries involved in interRAI right now. We have some wonderful colleagues from Hong Kong. Terry Lum, Vivian Lowe, Hao Lo, and Iris Chi are among our colleagues from Hong Kong that we're delighted to be able to collaborate with. In this graphic, the countries that have the bold italicized text are countries where we also have fellows actively involved in our mental health network. In Canada, the interRAI instruments are used extensively. All these little icons on the map of Canada represent implementations of different interRAI instruments across the country. So it's a pan-Canadian implementation of multiple interRAI instruments, including home care, nursing home, mental health, palliative care, and other assessment tools right across the country from coast to coast, as we say, because we have 3 coasts in Canada. So as of December of 2021, we had over 20 million interRAI assessments completed on about 6 million unique Canadians. So the interRAI instruments are very widely used and have a substantial impact on the health and well-being of Canadians. So it's reasonable to ask, why would interRAI begin doing its work on mental health systems, given that our origins were in long-term care and home care? Well, first of all, mental health is a very personal thing in the sense that it affects all of us. About 20% of Canadians experience problems with mental health or addiction at any given point in time. More than half of Canadians will experience mental health problems by the time they're age 40. And in fact, the New Zealand studies show that only about 17% of people live their entire life free from mental illness. And in some sense, you wonder, well, is that 17% the unusual population to have never encountered challenges to their mental health over their life course? We're also interested in mental health because it's a complicated issue. More than 70% of mental health problems begin in childhood or adolescence. And so for some people, this will mean a lifetime of experiences dealing with mental health challenges. Then the aging process itself has many different conditions and experiences that can have an impact on mental health. David Conn earlier talked about dementia, certainly is an age-related condition, and then the probability of depression can go up over the life course as we experience different life challenges and adverse events. If we think about the causes and the consequences of mental illness, they can include physical health and disability as both causes and consequences. Unemployment, poverty, deprivation, homelessness, substance use are all issues that can be both a cause of mental health concerns and an outcome related to mental illness. And if we think about our social relationships, certainly the relationships we have can protect us from stressors in our life and can support our recovery. But in some cases, the social relationships that people have can also affect their mental health in adverse ways. So it's a very complicated picture as you start to scratch below the surface to find out what's going on with mental health. We're also interested in mental health because it has such a widespread impact. Every country in the world is affected by mental health concerns. In fact, WHO says mental illness and substance use disorders are the world's leading cause of disability. And about 32% of years lived with disability have their roots in mental health concerns, and depression is about the 4th leading cause of total disease burden in 2000, and that continues to today. And then in many countries, we have to be concerned, including Canada, about stigma with mental illness leading to exclusion from participation in the larger society. In fact, mental health is so important that the US Surgeon General David Satcher said that there's no health without mental health. This is a fundamental part of our well-being must address. interRAI is also interested in mental health because you really need to take a systems-based approach to addressing mental health concerns. every part of the health and social service system has people who are living with mental health concerns. And that's true whether we talk about home care, nursing homes, inpatient psychiatry, community mental health services, palliative care, any of the major healthcare settings, primary care as well. But we can also think about educational settings, the welfare system, or criminal justice system. Mental health affects people using services of all types in all different settings. And we also had an advantage that interRAI had a head start in doing research in this area. So all of our instruments that we developed right from the early 1990s included a major set of mental health indicators. Our earliest nursing home instruments included measures of depression and anxiety, bipolar disorder, and schizophrenia, symptoms related to those conditions, as well as delirium and cognition, behavioral issues, interpersonal conflict, and psychosis were all integral parts of our nursing home assessments back to the early 1990s. And of course, that has expanded as we've created more specialized mental health instruments. So what did we do in order to respond to the challenge of mental health concerns? Well, it's summarized in this paper that we published a couple of years ago in Frontiers of Psychiatry. And I'd like to draw your attention to a new special issue of Frontiers in Psychiatry, where we've published about 20 papers about different aspects of interRAI's mental health research. So you can get a very deep description there of all the work that's been done over the last 25 years. So we've engaged over 250 different clinicians and researchers and policy experts working with us to create our mental health instruments and the care planning protocols associated with them. We engaged patients to help us with the design of clinical feedback systems based on those instruments. But a particularly important thing is we had over 1.5 million interRAI assessments in mental health settings to draw from, as well as about 12.5 million assessments from other instruments in Canada alone at the time that we started working on our major mental health instruments. This is the suite of interRAI mental health instruments. So we have assessments that begin with newborns to 3-year-olds. We have instruments for children and youth with mental health concerns. Then for adults age 18 and over, all the way through to centenarians living in long-term care and home care settings. So we cover all ages from birth to the end of life, community settings, facility-based settings, primary care, hospital-based services, home care, long-term care are some examples. We also have instruments that can be used as brief screening tools for management of risk, including a brief mental health screener for police officers who come into contact with persons with mental health concerns, which we're using to improve the response of police to persons who have mental health needs. So it's a fully integrated mental health system covering all sectors of the healthcare system and all age groups. It's a reasonable question to ask, well, why can we call this an integrated mental health information system? First of all, these instruments use a common language of consistent terminology across different instruments. If we're describing pain or depressed mood or psychosis, we describe it in a consistent manner using the same terminology across all instruments. We have a common theoretical or conceptual approach where we've designed our instruments to trigger care plans, where we ask enough questions to raise a flag to say, okay, this person needs an intervention in the area of behavior or substance use or depressed mood or cognition or what have you. There's a common clinical emphasis on function rather than focusing on diagnosis alone. We do track diagnosis, but we're more interested in the functional aspects of the person's day-to-day life that affect their ability to live their life the way they would like to live their life. We have a common approach to data collection. So clinicians will use their professional assessment skills using all sources of information available to them where they exercise their best clinical judgment about what's the most correct answer for a given domain that we're measuring. We have common core data elements that we use to measure across all populations. So for all individuals, we measure ADL function, cognitive function, depression, pain as examples of human characteristics that we measure irrespective of whether the person's in a psychiatric setting, a home care setting, a primary care setting, or some other context. And finally, for adjacent sectors of the healthcare system like home care and nursing homes, or community mental health services and inpatient psychiatry, we have common care planning protocols that can ensure continuity of care planning as people make transitions from one setting to another. If we're going to make claims about a systems-based approach, we need to be sure that our measures actually work on a system-based level. So one of the things we did was a 12-country study of inter-rater reliability, where we had independent assessors in different sectors complete interRAI assessments without speaking to each other. They did it with real individuals, not hypothetical case examples. And what our study showed is that we're able to achieve high reliability both within and between healthcare settings. This graph is in the paper that I've just shown you. And what it shows is that we get very strong weighted kappa coefficients for completely independent, very conservatively done assessments. And what this means is that when a clinician does an assessment in one setting, you can trust that assessment as being reliable in your own clinical setting. We can also look at reliability of scales across different settings using the Cronbach's alpha coefficient. The solid line across shows good to excellent reliability. And so with this graph, we're looking at 4 different clinical settings in many different, in 3 different countries with many different clinical domain areas covered. And you can see we get good to excellent reliability in virtually all of these study cases. And where we fall a bit short of that mark, that's where we used statistical tools like this to support additional training to be sure that we get to the standard we would expect in real use of these assessment systems. We also do work to look at validity across settings. So this is out of the paper that I mentioned earlier. We looked at how well the clinical characteristics in interRAI instruments are associated with diagnostic variables in the emergency screening for psychiatry, community mental health settings, and inpatient settings. And what we find is that the clinical signs like cognitive impairment are associated with diagnosis being present, like a neurocognitive diagnosis, for example, or misuse of prescription medications or heavy alcohol use is associated with a substance use diagnosis. This is not particularly shocking findings. It's just reassuring that, in fact, the clinical symptoms we're measuring are consistent with the diagnoses that are recorded on the person's chart, and that's true across clinical settings. But it's not enough just to do work on reliability and validity. You actually want to show that you can use these instruments to inform decision making. So this schematic shows the multiple applications of interRAI instruments for multiple audiences, where one assessment can generate data that can be used in a variety of ways. The most important side is the left side of this schematic, where we can use these assessments to develop person-specific care plans and track outcomes of care over time. And so I'll show you a couple of examples of that. But we can also aggregate the data at the population level to inform resource allocation decisions based on case mix-based funding, for example. And we can track quality of care through risk-adjusted quality indicators, comparing quality across different service settings. And I'll show you an example of that as well. If we think about outcome measures, how would we want to use those? Well, we want to, first of all, use them to measure the severity of the person's symptoms at any given point in time. How severe are their depressive symptoms? How severe are the indications of psychosis or behavioral issues or cognitive impairment? So we understand where the person is right now in terms of the intensity of their levels of need. But we also want to track those person's changes over time. If we're interested in measurement-based care, for example, as a methodology, we can redo interRAI assessments over time to see, well, are my interventions working? So the wonderful interventions that David Conn described that come from the various initiatives supported by CCM SMH, we want to see, well, if the person's engaged in that program, are they in fact improving over time? So you can repeat the outcome measures at multiple points to track person-level changes. And you can also use these scales as a starting point for decision support tools like eligibility criteria or resource allocation or risk management tools, for example. You can also use them for cross-sector comparisons and evaluations to see, are you doing a good job in one sector compared to another? What's the distribution of needs of people in one setting compared to another? Can we find ways to keep people in community settings longer rather than having them in facility-based settings? So outcome measures can be used for these various purposes. And I'll show you two examples, one related to cognition and the other related to a new scale or a new set of scales that we've created around mood disturbance. Our cognitive performance scale is a scale with scores going from 0 to 6, where 6 is very severely cognitively impaired. We have validated the scale against the mini mental state exam and the MOCA across many different clinical settings. And what this shows you is the cognitive performance scale score for almost 2 million unique Canadians receiving care in inpatient psychiatry, palliative care, community mental health services, social services called community support services, home care, post-acute hospitals that we call complex continuum care hospitals, and nursing home settings. And the green part represents people with mild to no cognitive impairment, and the red and black part are folks that have very severe cognitive impairment. So you can see as you move from left to right, you see fewer people who are cognitively intact, more people who are cognitively impaired. Now, it's interesting to note that for folks that are in inpatient psychiatry, there's relatively little cognitive impairment in the general adult inpatient psychiatry population, where the mean age of the population is age 45. Whereas if you look at the nursing home population on the far right, you see much more severe cognitive impairment in that setting. But if we look at two transitional populations, we see something interesting. So I'll use my laser pointer here just to highlight this a little bit better for you. So this group in this row are people who are in inpatient psychiatry that previously had resided in a nursing home setting. And on the far right are people who are now in a nursing home setting who are admitted from inpatient psychiatry. And you can see both populations have much more severe cognitive impairment than their counterparts that did not make that transition. So nursing home residents who go to inpatient psychiatry have more cognitive impairment than the general inpatient psychiatry population. Psychiatric patients who are admitted to nursing homes have more severe cognitive impairment than the general nursing home population. And so this gives a nice example of where you want to think from a system point of view, because it's not only about the people that are within one setting where you may want to understand what their needs are, but you also want to think about these transitional populations that move from one setting to another. I'd like to now talk about a new set of mood scales that we've created that enhance our ability to measure mood disturbance. These are described in this new special issue of Frontiers in Psychiatry that I mentioned earlier. All of these are open access articles, so you'll be able to get them directly. Within interRAI, we have something called the Depression Rating Scale. I was one of the original co-authors of that scale. It's been very widely used for more than 2 decades, but we know that it's got some limitations. For example, it does not measure items related to anhedonia. We know that anhedonia is an important dimension of depression. So if we're trying to get at depression or depressive symptoms, that's an important gap in the DRS. And it's also intriguing to note that clinician ratings give different answers from self-rated tools. So if you look at the Depression Rating Scale and the Geriatric Depression Scale, they're both strongly associated with psychiatrist diagnosis, but not particularly associated with each other. So they're measuring something different. Now, we were interested in creating a mood disturbance scale that was not going to be used as a diagnostic tool necessarily, but it could measure either an ongoing depressive state or a transitional state of mood disturbance related to situational problems that may be affecting the person at a given point in time. And what we want to do is have a compatible measure of mood disturbance that works across all settings and all populations, irrespective of who they are or what their level of cognitive function might be. So in this study, we examined about 500,000 individuals in 9 different clinical settings. So we looked at community mental health services, home care, community support services, primary care, long-term care settings, palliative care, emergency departments in acute hospitals, and 2 general population surveys that were just, in one case, random digit dials of the general population, and another an online survey done during the COVID pandemic. Each of these settings have people of very different ages. So the community mental health sample, about 90% of that population is under 65, whereas in the nursing home population, about 80% of the population is over 75, so different age structures. But there are also real differences in cognitive function, where in some settings there's little to no cognitive impairment, but in others there's more cognitive impairment, resulting in missing data if you're to rely on a self-report tool only. So in the paper, you'll be able to see the schematic in more detail, but we have 3 different variants of our mood scales now. We have a purely clinician-rated version that uses 4 items that can be used retrospectively with our older instruments if you want to do backward comparisons, but you can do that with the DRS as well. Of particular interest is we have a new self-rated scale that uses 3 items that can be used in general population surveys, as well as clinical self-report tools like our new interRAI checkup instrument. And then we have a composite mood scale that uses 7 items, 4 that are clinician rated and 3 that are self-reported. We start using the self-reported measures. We substitute the clinician's ratings if the self-report is missing, say because of cognitive impairment, or if the clinician's severity rating is higher than the person's rating. So the composite mood scale will give a higher score of intensity than if you were to rely on self-report only. All 3 scales have a range of scores from 0 to 9, where 9 is the worst level of mood disturbance. We've done a great deal of testing in terms of reliability and validity for this. So our previous work has shown strong inter-rater reliability for these items, and we get good to excellent Chromax alpha values for internal consistency of these scales in these different clinical settings. From a validity point of view, well, we look at the literature in terms of what it says should be considered in measures related to mood disturbance or depressive symptoms. We've done a good deal of work around convergent validity, looking at how these scales are associated with a mood disorder diagnosis, with problems with sleep, and with self-harm behavior using the mental health data. We've done criterion validity testing against the Kessler-10 psychological distress scale, and we're now moving on to do further work around predictive validity to track outcomes over time. So this is another graph similar to the one I just showed you for the cognitive performance scale, but this time looking at those 9 clinical settings using both the self-report and composite mood scales. The green part of the bar is the score of 0, where there's no indications of mood disturbance. And the red part of these bars is where there's severe mood disturbance associated with self-harm related ideation in the mental health data. And so not surprisingly, you see higher rates of severe mood disturbance in a community mental health population and relatively low rates in the general population prior to the COVID-19 pandemic. But somewhat surprisingly, in 2021, when we did an online survey of the general population with the self-report mood scale, we saw levels of mood disturbance in the general population of adults that was comparable to a clinical population in community mental health settings. And this type of finding has been replicated in several other studies where the rates of mood disturbance have been very high, at least in Canada, during the COVID-19 pandemic. And this is the graph that shows you the validity against the Kessler-10 psychological distress scale. You see there's a strong correlation of 0.73, and the scores that we use for cut points for severity of the self-reported mood scale correspond to the Kessler-10 cut scales, cut points for severe mood disturbance according to the Kessler-10. So these new scales give us a new capacity for better cross-sector measurement of mood disturbance. We're now recommending that this be pursued as an alternative to the DRS. Certainly we can continue to use the DRS with historical instruments, but in our future instruments within the interRAI standard, we'll be switching exclusively to this new set of mood scales. We now want to do further international testing outside of Canada. We want to look at its predictive validity for future diagnoses as well as self-harm behavior, and we want to expand the range of populations that we're testing this with further, and also to start to look at how we can use this for quality indicators related to quality of care in different settings, and how it might also be used in case mix classification systems like the RUG3 case mix system. Next, I want to move on to our care planning protocols, or our clinical assessment protocols, which are used to take the assessment data and trigger person-centered care planning interventions that focus on the individual's strengths, preferences, and needs. Our basic principles when we created these mental health caps was to draw from the scientific evidence in terms of assessment guidelines, but also to use our own data to develop evidence-based triggers to inform care planning interventions. Our focus on all of these care planning protocols was to incorporate the principles of recovery concepts where we could support the person's recovery from mental health concerns at whatever stage of impairment or mental health condition that they were facing. The emphasis is on a collaborative approach to care planning, where you're involving the person and their support network in a shared decision-making approach to supporting their recovery from mental health concerns. So we didn't create a robotic care planning library. Instead, we designed a methodology for engaging the person in shared decision-making. And what we're trying to do is focus on all aspects of the person's quality of life in as many domains as we can, using multidimensional interventions. And we're trying to support the person's autonomy as much as possible, irrespective of what their current level of functioning might be. We have care planning protocols around patient safety issues like self-harm and harm to others and inability to care for self. We have some that deal with the person's social life, with economic considerations, with threats to their autonomy, as well as physical health promotion, care planning protocols for our mental health instruments. So we don't just focus on mental health issues, but also some of those physical dimensions of need that may complicate recovery from mental health conditions. In Canada, we have an organization called Accreditation Canada, and they release documents called Required Organizational Practices. In this case, it's one related to suicide. And what they say is that every sector in the healthcare system must assess and monitor for the risk of suicide for their clients or service recipients. So that includes identifying people at risk, reassessing that risk at different intervals, addressing immediate safety issues that affect the person's personal safety, and then having treatment and monitoring strategies in place to see how the person is recovering. So it's reasonable to say, well, where does interRAI fit into this mix? We've created direct measures of suicide risk in our emergency screener and inpatient psychiatry, community mental health, and child youth mental health instruments, where we have a decision support tool called the Severity of Self-Harm Scale. And then in our nursing home, home care, and community support service assessments, we have more indirect measures that also deal with elevated risk of self-harm based on research that Hao and I have published, as well as I've published with some of my previous PhD students. So we have care planning protocols in place that can help you directly respond to the directive of Accreditation Canada around purposeful self-harm. It might be a bit tight to see the schematic, but what it deals with is it's a decision tree model that we created with some machine learning tools that relies on indicators like current self-harm ideation, having a history of suicide attempts, the severity of depressive symptoms, having a suicide plan in place, whether there are family members concerned about self-harm, as well as other aspects that could lead to non-purposeful self-harm, like psychosis or cognitive impairment or other types of functional challenges. These scales are associated, can be grouped into different risk levels. So the scale goes from 0 to 6, where 6 is the highest risk levels. And if we compare their distributions across different settings, on the far left, you see the distribution for the self-harm care planning protocol that uses that scale. And we have the lowest rates of risk in community mental health settings. And that's probably why people are able to receive mental health services in the community, because the risk levels are not elevated. But if you move to an emergency department or to new acute admissions to inpatient psychiatry, you see in the red, the high-risk group for self-harm has jumped dramatically to over 20% of the population for acute inpatient psychiatry. But we also see folks in inpatient forensic services, inpatient geriatric psychiatry services, and long-stay inpatients in mental health settings with very elevated high levels of risk of self-harm as well. Whereas if we focus on self-care as an issue, we see in community settings and inpatient geriatric settings, the highest levels of risk around self-care. Most of that is in the moderate risk level rather than the very high risk levels for that particular indicator. Now, it's reasonable to ask, well, how do we know that the severity of self-harm scale works? What have we done to validate that scale? Well, we started with modeling clinician ratings. So when we did the assessments, we asked clinicians to say, based on their subjective appraisal of the person at that point in time, how severe was that person's level of risk of self-harm? Was it minimal, mild, moderate, severe, all the way up to imminent risk of self-harm? And what you can see is that this scale is very strongly related to 90% of people are rated as having minimal risk, and nobody is above the moderate risk level. Whereas for the sixes, only about 10% of individuals are scored as having minimal risk, whereas half are in the severe, very severe, and imminent risk categories based on clinician ratings. If we look at the relationship between the reason for admission to inpatient psychiatry, in this case, we stratified it by different age groups to show that it works with young people and elderly individuals. Each 1 point increment in that scale is associated with roughly a doubling in the odds that this person was admitted due to self-harm related characteristics. And the C statistic is a marker of how well the model performs. In the case of 10 to 17-year-olds, it suggests that 80% of the time you get a coin toss yielding a heads. That's a very high level of accuracy for this type of predictive scale around something like reason for admission. If we're to take extreme scores of a 0 compared to a 6, that would be a 64 times increase in the odds that the person was admitted due to self-harm based on that scale. Next, we looked at actual inpatient self-harm behavior. So we looked at reassessments over time to see were the patients engaged in self-harm while an inpatient. And what we can see is that with the high-risk category of the care planning protocol for self-harm, the odds of inpatient self-harm during the stay were 13 times greater based on their self-harm scores at admission as we tracked the people up over the period of time to discharge. And the last example was we were able to model this against 90 deaths that occurred as inpatient deaths by suicide, a tragic event that you do not want to see in any setting, but is also something that psychiatry works very hard to prevent. And what we found is that the admission scores on the self-harm scale, when they were in the high-risk category, those folks had a 6.8 times greater odds of death by suicide while an inpatient in inpatient psychiatry. So what we know about this CAP is it predicts clinician ratings, why people are admitted, inpatient self-harm attempts, and deaths by suicide. And it provides guidelines created by interRAI as a multinational team of experts using valid triggers for intervention and a careful review of international best practice guidelines to target suicide-related interventions. And finally, I want to close by showing you work that we've done on the impact of COVID-19 in long-term care homes in Canada. Our country was very severely affected by COVID-19 in the initial waves starting in 2020. We're still experiencing waves of COVID-19 today. We're about to start another wave by the looks of things. So that would be our 8th wave of COVID-19 in Canada. But in those first 2 waves, it was particularly devastating for older adults in long-term care settings. So in nursing homes in Canada, in those first 2 waves, about 10,000 residents died due to COVID-19. So the impact on mortality was profound in this particular setting. But we're also interested in outcomes other than mortality to see what happened. And so this is using that older depression rating scale, because in the nursing home settings, we're still generally using our older instruments. We haven't yet moved to the newest standard of instruments. This shows you trends in depressive symptoms over time. Green are people with a low score on the DRS scale, and red are people with a high score that have a higher probability of a depression diagnosis if you were to check that against that scale. What's interesting is that in many provinces, what we see is that there were trends of improvement in depression scores over time. So if we look at my province, Ontario, we had about 30% of people showing very severe depression over time. That improved somewhat to around 25%, but then in the pandemic, it stopped. In Manitoba, we had lower rates of severe depressive symptoms, below 20%, and that improved to the point of around 15% by the time of the pandemic, but it flattened out. So in many of these provinces, what we saw was not an explosion of depressive symptoms, but rather a slowing down of improvements in quality of care, leading to improvements in depressive symptoms in nursing home residents. We had an opportunity with our newest instrument, the interRAI LTCF, to do a study in New Brunswick, one of the eastern provinces, in the first wave of the COVID pandemic. What was interesting there is we were able to model the impact of lockdowns in long-term care where COVID was not present. In the March period to July period of 2020, Ontario had widespread COVID infections in long-term care, but New Brunswick had none. There was no COVID in that province at that time. They did have lockdowns, so we could evaluate the impact of that social intervention to lock down those homes while there was no COVID present. And what we found is that there was no effect, or in some cases even a mild protective effect, during the lockdown period on behavior disturbances, depression, and delirium. And those are models that control for a host of covariates, including historical variables, demographic variables, diagnosis, and different clinical symptoms and facility level indicators. It's reasonable to ask, what did those homes do to avoid severe mental health consequences of that relatively extreme intervention of locking down access to the home? Well, what they did was to increase recreational services so that there were more things for residents to do in the homes while the lockdown was present. They hired students to increase the staffing component in the home during that period. They deployed electronic tablets to connect residents with their family members, and they used a communication strategy to keep family members engaged and informed what was happening. So in these homes that are in not a particularly high resource part of the country, they were able to deal with the initial effect of the lockdown very effectively. Now, what we don't know is 2.5 years later, is that still true? One of my PhD students, Ree Mulla, is now doing her PhD to look at the entire pandemic in multiple provinces to see over the long haul, are we still seeing relatively moderate effects on mental health, or does it start to become more problematic as the pandemic wore on? One troubling change that occurred was around inappropriate antipsychotic use. This is a paper that we published in the Journal of the American Medical Directors Association on a pan-Canadian intervention to improve quality of care with respect to antipsychotic use. So we were looking at inappropriate use of antipsychotics in long-term care homes. The intervention homes, excuse me, employed a unique intervention put forward by a national agency on quality in healthcare, whereas the control homes were implementing interventions that the rest of the country was doing. Everybody was sensitized to the need to reduce antipsychotic use across the country, but the intervention homes were using a special intervention put forward by the Canadian Foundation for Health Quality Improvement. And so what we can see is that in both settings, there was an improvement in antipsychotic use, so that the median rate of antipsychotic use went down in the best homes. Those with the low in the 10th percentile had lower rates of antipsychotic use, and that was true for the worst homes. and the impact was bigger in the homes using the collaborative intervention compared to the secular trend that was happening in the control homes. So we had a great success story here nationally up until 2019, where we were reducing antipsychotic use. We still had more work to do. There's still too much use, even at 20%, but we had this very wonderful concerted effort to be more appropriate in the use of these medications. Then along came the pandemic, and what we've seen in every province, except for Manitoba, the use of antipsychotics has started to go up again. So in my province, Ontario, we're now back to almost 30% of residents receiving antipsychotics, where we were down to 25%. We look at inappropriate antipsychotics, we were down to about 20% overall. So this is troubling in a number of ways, because so much effort was put out in the country to get rid of this inappropriate pattern of antipsychotic use. And it's a bit disheartening after the pandemic to now be feeling like we're kind of back at square one, where we need to start over again. As we've looked at the data, however, what we're noticing is that a good part of this is a function of people being admitted from acute care with antipsychotics. And in fact, the percentage of new admissions coming from acute care has increased during the pandemic. Because what we've tried to do is to protect space in hospitals by moving people into nursing homes more rapidly than we did in the past. So the case mix of the nursing home population has changed to have more hospital admissions, and those hospital admissions are more likely to come with an antipsychotic. Now, that doesn't mean it's not the nursing home's problem. The nursing home has to find a way to wean the people off of antipsychotics when they're inappropriate, but to some extent, their efforts to try to improve this practice pattern are counterbalanced by these other pressures to deal with people coming from the hospital system with antipsychotics in place. So I'm going to end there to say, how you can use interRAI instruments is to respond to mental health concerns of a variety of types. I've shown you examples related to cognition, mood disturbance, suicide-related behavior, and inappropriate use of antipsychotics are just 3 or 4 mental health examples. And so you can improve quality of mental health care within settings, but you can also work across care settings and respond to mental health needs over the entire life course. And when you use interRAI assessments, you can use the same data elements in a variety of ways to serve different needs for different stakeholders, whether it's clinical care at the person level, resource allocation and quality improvement at the management level, or policy level applications if you're thinking about population level data. All those different stakeholder audiences can use the same data sources to address key decisions that they need to make. I'll stop there and open the floor to questions and comments.
Thank you very much, Professor Hirdes, for your very comprehensive and exciting introduction about what interRAI can do. And we are now open for questions from the audience. Okay. So as we are sourcing questions, may I take the liberty to just ask one question on the instruments you're designing, just published in Frontiers about the mood disturbance. So in our JoyAge project, we are also curious about how to best capture the risk factors, also do the early assessment and then probably diagnosis, intervening for those older people with mental health needs. And other than just using some scores and cutoff scores, we're looking at different symptom networks. And do you have any experiences or any recommendations on how to, especially in older adult population, what we notice is the high comorbidity of different symptoms across different probably dimensions. So do you have any recommendations or thoughts about it?
Yeah, so the high comorbidity is an example of the complexity that I mentioned at a couple points in the talk, that these things are so intertwined that if we take a look at pain, for example, we know that pain can sometimes be a symptom of depression. Pain can also lead to depressive symptoms. If you have chronic persistent pain, you sort of lose a bit of hope sometimes that it's going to get better. So it can be both a consequence and a cause for it. So if you really want to understand depression, you also need to pay attention to somatic concerns around pain. Similarly, if you think about addictions issues, pain and addiction for opioids can be very tightly connected, and so you can have substance use concerns for people in addition to mental health concerns. Other comorbid conditions can manifest themselves in terms of mental health indicators, whether it's a confused state or behavioral symptoms. So, we can't just take a simplistic approach to older persons or persons with disabilities or persons with chronic illness, because everything is interconnected. And so it needs that multidisciplinary cross dimension view to it. But you can also keep it simple where it's appropriate to keep it simple. So in populations that are relatively healthy and cognitively intact, a simple self-report tool can work very nicely, like we did with our telephone-based screening. But if we think about people in a nursing home setting or palliative care patients, that's where having this composite approach of using both clinician ratings and self-ratings can be useful. In our nursing home population, we have about 30% of people who are not able to respond to self-reported questions. So the clinician-rated questions become important in that context to get a true picture of depressive symptoms. However, if I want to do a population level surveillance of everybody in the population during a pandemic, I can't have clinicians interviewing every Canadian or every resident of Hong Kong. And that's where the self-report tools can be so helpful.
True. Great. Thank you for really giving us a whole picture of how these different instruments can be applied to different settings and populations. We have one question from the audience. Not sure if you have already mentioned, is there any recommendation on how to encourage the clinical settings of hospitals not to use too much medication?
Well, I think the first thing is by measuring it and comparing it, that provides you a context for understanding where too much medication comes into play. So our quality indicator for antipsychotic use, among other things, includes exclusion criteria for where antipsychotics may be appropriate or not appropriate. So for example, we do not have a problem with using antipsychotics where somebody has a psychosis diagnosis or active indications of psychosis. Antipsychotics are entirely appropriate there. But sometimes there's recommendations to use antipsychotics to manage behavior disturbance associated with dementia. And the challenge there is we don't know what the right minimal level is. So many people would say, well, the answer is not zero, that you can't drive it down to zero, because sometimes an antipsychotic could be appropriate if there's a delirium or in some cases where behavior is very difficult to manage, it might be useful as a short-term intervention. But by benchmarking yourself against others is where you can start to see where your rates are too high. When we began this work in Ontario, we could show that, well, we had over 35% of residents where the use of antipsychotics was potentially inappropriate. The Winnipeg Regional Health Authority had already driven it down by 10%. And in the United States, the rate of inappropriate antipsychotic use is much lower. And this is where the connection to interRAI becomes very exciting, because when you can compare yourself against international practice patterns, you sometimes gain insights about practice patterns that are maybe accepted in your country that other countries would not be comfortable with. When I began my career, I started with a focus on physical restraint use, and we found that the rate of physical restraint use in Toronto hospitals was around 40%. And everybody said, well, 40%, I guess that's our rate. But then we saw rates in Sweden, Denmark, and the United States that were between 5% and 15%. We realized we had a big problem. And we used that to drive a major national intervention to reduce restraint use. And now our national rate is below 5%.
Yeah, John, thank you for the inspiring presentation. I talked with the people in the social welfare department. So we have a very kind of fragmented mental health system in Hong Kong. One is we have a healthcare system which is very specialist driven. But we only have a little bit more than 400 psychiatry and 600 clinical psychology for 7.4 million people. So they only have, mainly they have capacity to deal with SMI, but typically not common mental disorder. And then we have a social welfare system, which at the past is also mainly helping people with SMI discharged from hospital or institutional environment. Then we integrate into the society. So they look into the family relationship, job employment, community integration of people with SMI. But now the major challenge is not only in SMI, it is more on common mental disorder. So however, in the system you kind of talked about is a very good integration. I would say it can be used for both medical care as well as social care. But in a very fragmented system like what we have in Hong Kong, and if we're starting from social care first, so what instrument from interRAI would you recommend if we want to have a standardized, instrument for all, community-based social care system for people with mental disorders, particularly with common mental disorders?
Okay, well, let me break apart the question, Terry, into a couple of different components that I think are important to emphasize. The first is that limited health human resources is not a Hong Kong only problem. Mm-hmm. It's true around the world, where we don't have as many highly trained clinicians as we would want for the mental health needs of populations. One of the things that we gain with having a standardized assessment and measurement tool in place like interRAI offers is the ability to identify degrees of complexity in the populations. So at least if we have limited resources, we get the people with the most complex needs, or the people that are the best match for those intensive resources to get those services. And that is at least a bit more equitable as an approach, that we can allocate resources based on need. The second thing that I would say is that our instruments can be thought of as education and training tools to expand the expertise of the overall health human resources. So to help people in primary care or in home care or in nursing home settings be better mental health clinicians. So we have care planning protocols around depressed mood that would be very consistent with what David talked about in terms of the CCMH guidelines around depressive symptoms. So these are educational interventions that also build the capacity of the general clinical population to deal with mental health needs. So you don't always have to refer to a specialist for every type of mental health concern, that we can have a better match of the scope of practice and the types of mental health needs that different types of individuals could use. In forensic psychiatry, we have an interesting problem. In Ontario, it takes about 4 months before a clinical psychologist will be available to do a forensic psychiatry risk assessment. And so you're waiting for 4 months to manage risk around a new forensic psychiatry patient. But with our interRAI mental health instrument and the forensic supplement, we can get those interventions and measures in place right from the point of admission and start managing those needs very early on. If I was to think about a general primary care population, I think I would take a look at the interRAI checkup instrument as a starting point. We're using this now in primary care in Ontario, as well as many low resource nations. It's a purely self-report tool. It can be used by a clinician in some cases. One of my colleagues is a geriatrician who uses it during assessments with people with more complex needs, but he has the caregiver present. The advantage of the checkup is it can be done by non-regulated health professionals, but it yields highly valid and reliable data that is consistent with the clinician-rated assessments on the home care side of things. So we see this as a tool to reach large populations where we don't have a lot of clinicians available, to find the subset of people that we should be referring for clinically driven home care services to match those needs appropriately.
Okay. But if we are talking about people already have, for example, diagnosis of mild to moderate, particularly moderate level depression in a community setting, so what instrument will you recommend?
So it depends on what else is going on there. If we're concerned about self-harm related behavior, or severe substance use issues, then the interRAI community mental health instrument is appropriately called for in that case. So it's a clinician-led tool, and it picks up some of that greater complexity where there also may be broad-based social impact on the person's functioning and their employment status. On the other hand, if it's, the person has depression, but not those other complicating factors, then the other instruments like the checkup or the home care instrument could be a good fit there. So it depends on the severity of the additional psychiatric complaints being present that would come into play. It's somewhere between probably checkup in primary care, the home care instrument, and the community mental health would be the three tools that are probably the best fit for different populations, but they're all designed as a system to work together.
Wonderful, thank you, John. I am aware of time. Let me pass the microphone back to Bridget.
All right. Thank you very much indeed, Professor John Hirdes and Professor Terry Lum, for very thought-provoking conversation. And thank you for everyone. And this concludes our third day of the symposium. And tomorrow will be our last day of symposium. And there will be a workshop which will be conducted in Cantonese about working with older adults with suicidal risk. So please follow us on Twitter, JoyAge, to learn more about our research. And Chinese speakers are encouraged to like us on Facebook as well. And see you tomorrow at 2:30 p.m. Hong Kong time.
Enjoy the conference.
Thank you.
Thank you. Bye.